I am very happy to introduce our next speaker. Dr. Adam Margolius is a movement disorders neurologist at Cleveland Clinic. He completed medical school at Case Western Reserve University, a neurology residency at Northwestern University, and then finished his training with a movement disorders fellowship at Cleveland Clinic. His research interests include the role of palliative care in movement disorders. And he is the director of our Huntington's disease clinic, as well as the palliative care clinic for Parkinson's disease, known as the CarePD clinic. Given Dr. Margolius's expertise in this area, we are honored to have him talk to you all today about the value of palliative care services for persons with Parkinson's, as well as care partners. Dr. Margolius, thank you for joining us.
Hello, everyone. My name is Adam Margolius. I'm one of the movement disorders neurologists at the Cleveland Clinic. Today, over the next 20 or 25 minutes or so, I'm going to be talking about the relationship of palliative care and Parkinson's disease, or the role that palliative care plays in patients with Parkinson's. And then I'm going to talk a little bit about what we're doing at the Cleveland Clinic, an interdisciplinary clinic with myself and a palliative care doctor called the CarePD clinic. So I'll be able to go over all of that. Okay, so first, what is palliative care? If there's one thing I want you guys to take away from this, it's really going to be, what does palliative care mean and what doesn't it mean? I'll tell you right up front, it is not the same thing as hospice. And I know the term palliative care can carry a lot of emotional weight for people. I'm hoping to kind of lighten that load just by defining it a little more clearly and letting you know what the differences are and the similarities between palliative care and hospice. And specifically, I'll be talking about the role that palliative care plays in Parkinson's disease. Okay, so what I have here is a definition of palliative care, actually from the World Health Organization. I'm not going to read the whole thing to you, but I want to point out a few important terms in their definition. First, palliative care focuses on improving quality of life. That's a term I'm probably going to say a few times over and over today. Quality of life, when we're in the palliative care mindset, that's the most important thing we think about, is improving a patient's quality of life. What that really means is improving their comfort, their happiness, their sense of fulfillment, really the quality of their life. That's our main goal. Mostly that's done by relieving troublesome symptoms. The one they mention here is pain, but as we know in Parkinson's, there are many, many other symptoms that affect quality of life. We'll talk a little bit about those in more detail later. But then in addition to relieving symptoms, with the palliative care mindset, we're also not just thinking about physical symptoms, but thinking about psychosocial factors like family dynamics, the burden that the patient feels and the caregiver feels, and then spiritual issues too, not religious necessarily, but spiritual. All of those things play a role in palliative care. Okay, so when we talk about palliative care, the goals are often a little different than the typical goals of a neurologist when we have a palliative care mindset. Like I said, the most important thing is improving quality of life. And the number one way to do that is by providing relief from distressing symptoms. Pain can be a big part in Parkinson's. You might hear some people say that Parkinson's doesn't cause pain. That's not explicitly true. I'll talk about that a little bit more later. But one of our main goals when we're thinking about palliative care is providing relief from pain and other distressing symptoms. When we're using a palliative care mindset, our goal is not necessarily to prolong life. Really, we're not going to hasten or postpone death by doing palliative care things. We're really focused on improving the quality of life day to day, the comfort, the fulfillment. By relieving symptoms, we try to allow patients to live as actively as possible each day at a time. Now, something a little unique about palliative care, it often involves a team-based approach. I mentioned there's not just symptom control, but we have to think about family dynamics. We think about what the caregiver is going through. We think about living situation. So for all those reasons, we tend to use a team-based approach. And in our clinic here, as I'll tell you, in the Care PD clinic, that means a neurologist, a palliative care physician, and a social worker. But often there are many other members of the team. Physical therapists often play a big role. Nursing is really, really critical usually. So hopefully that's giving you a little bit of overview about the goals of what we're going for with palliative care. Now, in Parkinson's, palliative care is not reserved for the end of the disease. Palliative care plays some role throughout the disease process, meaning from the time to diagnosis all the way to death. And that doesn't mean you need to see a palliative care specialist from the beginning, but your primary neurologist, your Parkinson's neurologist, does some primary care things. They provide emotional support at the time of diagnosis. That's considered palliative care. And when it's provided by your neurologist, not a specialist, they call that primary palliative care. But sometimes as the disease progresses towards later stages, when symptom management can be really difficult, when there's maybe communication difficulties or complex decisions need to be made, that's often when a palliative care specialist or a specialty clinic might become involved, and that's referred to as specialty palliative care. So at the beginning, your neurologist is probably providing primary palliative care, and as time goes on, you might have more needs and need some more specialty palliative care. Okay, this is a really nice slide from the Parkinson's Foundation that they were nice enough to provide. I haven't really talked much about hospice yet. Kind of wanted to lay down what palliative care was. So this slide compares and contrasts palliative care to hospice care, talks about what they have in common and what the differences are. So we already covered palliative care a little bit. Like I mentioned, it can be at any stage of the disease of Parkinson's, from the beginning, middle, and everything in between. It is typically provided alongside, palliative care is given alongside your normal therapies or other therapies. And that can include medical therapies, like most patients who are receiving palliative care, if they get sick with pneumonia or urinary tract infection, they would seek out hospital care and antibiotics and treatments to cure those infections. However, in hospice, our goal is more maximizing dignity and comfort towards the end of life. So when a patient is enrolled for hospice care, that is an acknowledgement that they're nearing the end of life, whether it be from Parkinson's or some other condition that they also have, like cancer. Typically, it'll be when we expect that they're in the last 6 months of life or less, but obviously that can be very hard to predict. So with hospice care, like I said, 100% the focus is on comfort, as well as dignity and quality of life still. But when someone's enrolled in hospice, we're not going to be doing interventions that prolong life. So typically that means less trips or no trips to the hospital. Typically you're not going to get antibiotics for an infection. Typically we're focusing just on comfort, and that's for hospice. Now, both palliative care and hospice care, they both have a time and a place. So they are both play an important role in Parkinson's disease for most patients. They both can be really helpful for patients and caregivers. Both tend to be given with a team-based approach, just like I mentioned for palliative care. Usually it involves doctors, nurses, social workers, often nutritionists, therapists, lots of other people too. And both of them really do, the primary thing is addressing symptom control, looking for bothersome symptoms and finding ways to alleviate suffering from those symptoms. So hopefully that's helps you guys clear up a little bit the differences between palliative care and hospice. So some overlap, but they're not the same thing. Many more patients get palliative care than hospice at any given time. Hospice really is reserved for acknowledging when we're at nearing the end of life. All right, so with that background, we can talk a little bit about what we're doing at Cleveland Clinic for patients with Parkinson's disease and palliative care needs. So I just finished my fellowship training last summer, and during the end of fellowship, I began preparing the groundwork for this clinic. And as soon as I started as staff, we started the Care PD clinic. You can see the acronym there. comprehensive assessment and treatment clinic for Parkinson's. It's a little bit forced, I know, but basically it's a clinic for patients with Parkinson's disease and palliative care needs, and where the palliative care needs have become a little more complex than the general neurologist might be used to handling. So the way we run our clinic, it is an interdisciplinary clinic. We use a team-based approach. Involves myself, Leah, our social worker, who you're also going to meet today if you haven't already, and then a palliative care physician, Dr. Samala. We all see the patient together in the room at the same time. So for each visit, the patient will be there with a caregiver, and it'll be an hour-long visit with all three of us. We find that makes things a lot easier, actually, for the patient and caregiver. It makes the day a little bit shorter, because I know even just having one appointment can make for a very long day. So it makes the day a little shorter and more manageable. Makes it so you don't have to repeat yourself over and over again. And we find it's a lot more efficient, and everybody benefits from that format. Typically, this clinic is for patients with Parkinson's disease who are really struggling with the non-motor symptoms of PD. You've probably heard that term before, but what non-motor symptoms mean, it's in contrast to the motor symptoms. So motor symptoms of Parkinson's are any symptom that involves movement. So that's tremor, stiffness, slowness, walking problems. Those are the biggest ones. They call those motor symptoms. Now, early on in the disease, usually motor symptoms are predominant, but as time goes on, these non-motor symptoms can affect quality of life much more. There's a long list of possible non-motor symptoms. It's different for every patient, but basically that means everything else that you might experience with Parkinson's. So that's things like confusion or memory problems, things like low blood pressure, which can have an enormous impact on quality of life, pain, and many other symptoms. I'll actually talk about them a little bit more in a bit. The other reason we see patients in the Care PD clinic is if they're looking for assistance with advanced care planning, meaning thinking about things like maybe changing living situation from home to a nursing home, or thinking about what kind of interventions you might want or not want if you were to become very ill. Things like wanting artificial breathing or feeding, we can help facilitate those kinds of conversations. We now know that these clinics work. So there's about a dozen or 15 maybe now of this similar types of Parkinson's palliative care clinics in the US. And just last year, a big randomized study was published where patients with Parkinson's and palliative care needs were randomized to either be enrolled in these specialty clinics or just to continue to get their usual care with their neurologist. And the patients that ended up going to these specialty clinics had higher quality of life and better control of their symptoms, both. So these clinics do provide a good service, and now we've proven that. Okay, so a little bit more, I touched on this earlier, but on the left, part A of this figure, you see the typical model of how neurology specialty care is given. That NC means neurology clinician. So typically the neurologist sees the patient, and then they decide to refer to physical therapy, speech therapy, social work, kind of in a piecemeal matter. But with an interdisciplinary clinic, it's the patient and caregiver seeing these other clinicians all in the same half day, or in our case, all at once. And for us, it's a social worker, a neurologist, and a palliative care doctor. Okay. So now I want to take the next few minutes to go over some specific non-motor symptoms that are common in late-stage Parkinson's, the kind of symptoms that we manage a lot in the Care PD clinic. So first, I touched on this earlier, but this is a really nice study that shows the difference of what symptoms affect quality of life early in the disease versus late in the disease. So this study from about 10 years ago, in a Parkinson's clinic, they interviewed every single Parkinson's patient who came in, and they just asked one question. They said, what are your most bothersome symptoms? What bothers you the most? What's your top 3? Now, this first table is for patients with early Parkinson's, where they've had it for 6 years or less. And you can see the most bothersome symptoms tend to be those motor symptoms. slowness, tremor, and stiffness are the top three. And then the first non-motor symptom comes in as pain at number 4. And then you can see the rest of the list is kind of a mix of motor and non-motor. So early in the disease, the motor symptoms tend to bother people the most. Now, this is later in the disease for people who've had it for 6 years or longer. You can see the number one most bothersome thing is fluctuating response to medication. I'm sure a lot of you have experience with that because it's very common as time goes on, where the medicine might work, but it doesn't last long enough, or it works, but it comes with side effects, and it tends to wear off, or sometimes it works and sometimes it doesn't. So maybe it's predictable, maybe not. But in any case, a lot of ups and downs during the day, and that can be very troublesome. And then look at the next few symptoms on the list. They tend to be the non-motor symptoms of the disease. So mood, like anxiety, depression, or apathy. Drooling can have a huge effect on quality of life. And sleep problems. And then you see tremor in there at number 5. And then after that, pain and some other non-motor symptoms. So the takeaway is that early in the disease, the motor symptoms are the most bothersome. And as time goes on, it's those non-motor symptoms that tend to have a bigger impact on quality of life. So as time goes on in Parkinson's, as the treating physician, we change our focus a little bit. Sometimes not worrying about a tremor so much, but worrying more about, mood and other non-motor symptoms. And sometimes that means cutting back on the Parkinson's medicines to help alleviate some side effects that might not have been a problem early in the disease, but as time goes on, patients are a little more prone to side effects from Sinemet and other Parkinson's medicines. So sometimes we end up cutting back as time goes on. Okay, so in our CarePD clinic, every patient fills out a couple surveys with the help of their caregiver. This is the most important one, I think. It's called the Symptom Assessment System for Parkinson's, or ESAS-PD. Basically, it's just a list of symptoms, mostly non-motor, and then the patient can circle how much it's bothering them, 0 all the way up to 10. You can see the first item is pain, then tiredness, then I have a list of other symptoms at the bottom. That really helps us guide the conversation in the CarePD clinic, knowing what symptoms are affecting the patient the most. So pain is common in Parkinson's. It is more common than in the regular population. About 80% of patients with Parkinson's experience some form of pain, and most of that is actually directly related to Parkinson's in one way or the other. Often it's from rigidity, that stiffness that you can have that can create a lot of tension on muscles and joints, and it can make arthritis worse. It can be very painful. Part of it is from the posture when you're walking, may contribute to back pain. Some people with Parkinson's just have an unpleasant, painful feeling in their body that can be really tough to treat. So for a lot of different reasons, pain is a symptom that we see in Parkinson's, and that's something that we assess thoroughly in the CarePD clinic and take time to address that. Now, there's a list of symptoms that can be bothersome in Parkinson's called autonomic systems. That's what we neurologists call it. Basically, the autonomic nervous system is everything that should be happening on its own. So like your bowels moving normally, the nervous system is involved, but if it's impaired, like it gets in Parkinson's, constipation can be a problem. Also, your nervous system is involved in regulating your blood pressure. Normally, when you stand up, your brain cells should tell the blood vessels to tighten up a little bit so your blood pressure doesn't drop. But in Parkinson's, especially advanced Parkinson's, that reflex can become impaired and people's blood pressure can drop a lot, even leading to fainting or falls. That's called orthostatic hypotension. So I'll go over each of these symptoms briefly, but generally in the CarePD clinic, the first thing we always think is, are medicines contributing to this problem? So instead of our first instinct being to add a medicine, first we think, should we cut back on any medicines? Should we be taking anything away? Sometimes in the palliative care population, less is more. We find that cutting back on medicines and relieving side effects can have a great deal of benefit. So those Parkinson's medicines can make that orthostatic hypotension worse sometimes. So we might cut back. There are meds that can help bring up the blood pressure that we sometimes try. For urinary symptoms, There are some medicines, but they tend to have side effects, so we have to use those with a balance. Sometimes improving quality of life can be as simple as having a bedside commode so you don't have to walk to the bathroom 5 times in the middle of the night. And then patients might find it's much easier to fall back asleep if they only have to get up and walk a foot or two. Drooling is a common problem. Sometimes there are injections that we can do to the saliva glands. So this way we don't have to add another medicine. It's just a quick injection you can do once every few months to help somebody make less saliva, which can have an enormous benefit on quality of life. And there are lots of over-the-counter treatments and things for constipation. Constipation is treatable. You just often have to be more aggressive than you think. It's not something that you want to get behind. It can cause a lot of discomfort. So mood symptoms are pretty common in Parkinson's too, certainly more so than the average population. In advanced Parkinson's, hallucinations and delusions can be a symptom for some patients. People may see, they tend to just be visual hallucinations, meaning no sound associated with them, but you may see other people in the house or animals, and those can often be alarming or frightening. You might not be able to realize that it's a hallucination. Delusions is, what a delusion is having an idea in your head that's not true, but being unable to shake it no matter what. So sometimes that might be a sense that someone is going to arrest you, or that someone is stealing money from you, or that even that your spouse is being unfaithful to you. Those are some examples of common delusions we might see. Sometimes cutting back on medicines can help with hallucinations, because we know that can be a side effect from a lot of Parkinson's medicines. Sometimes we add a medicine for this. There's one called Nuplazid, which is FDA approved and works very well. And there's a couple other medicines that, while not FDA approved, are also beneficial that I listed there. Sleep can be a big time problem for people. And if you're not sleeping well at night, that's going to make every other symptom worse during the day. Typically, melatonin is the first line treatment. Just simple over-the-counter melatonin can have a big impact. And then sometimes there are prescription medicines here too. Sometimes it just involves talking about what's keeping you awake at night. Maybe it's anxiety, maybe it's pain, and addressing those symptoms. But sleep is something important to certainly look into to help improve somebody's quality of life. So cognitive impairment, either mild or to the point of dementia, is common in Parkinson's, especially people who have had it for 10 years or more. Not everybody will get dementia or cognitive problems, but some people do. And as we know, that can have a huge impact on quality of life. It can have a huge impact on your relationships with your spouse or other family members and friends. Often here, the first thing we look at is what medicines are contributing to confusion. So sometimes if someone is having problems with thinking or memory, cutting back on Parkinson's medicines might actually help them think clearer, be less confused. And then there are some medicines that have some benefit that we might add, but we just have to keep in mind that the benefit is pretty mild from those medicines, but often they're worth trying. In general, having a large medication burden can have a big impact on quality of life for the negative. So this is something we always look at, the medication list, when we think about what medicines do you need, which ones are doing nothing, and which ones are causing harm. And we always try and cut back and simplify the medicines. And we think, are there things that aren't medicines that could give you the same benefit? So any way we can shorten that medicine list usually helps improve side effects and helps improve the amount of burden or work for the caregiver, whoever's organizing those medicines. So cutting back can actually have a meaningful improvement in quality of life. So I think I've touched on this, but in the Care PD clinic, something that makes us a little unique is we formally assess how the caregiver is doing, because we know the health of the patient is really dependent on the caregiver. That caregiver's well-being is really important too. So we make sure that we kind of assess the balance of how much they're able to take on, how much work they have, what is their health, what is their kind of mental health. Do they need a break? Do they need a little help around the house? These are all kind of things we can look into and try and give some relief for, and it's really important. Okay, so I know I covered a lot in that brief 25 minutes or so. Main things I want you guys to take away, just keep in mind palliative care, it shouldn't be a scary term. It's an important part of care in Parkinson's disease, and it's distinct from hospice, as we talked about earlier. I hope I made clear that those non-motor symptoms are what become especially have an impact on quality of life later in the disease. Unlike early in the disease, it's mostly motor symptoms. Later in the disease, it's those non-motor symptoms. So that's what we tend to focus on when we're in a palliative care mindset. And then last point is these specialty clinics like the one we have here, they can help. They really can make a difference, our Care PD clinic. Okay, thank you so much everyone for your time.